See, I'm sorry.
I'm sorry, was there a question?
Yeah, I'm sorry. I just thought of this right now. But so when we go to clinic today, are we setting up 3 units or
I would
2?
set up, yeah, I would set up 2 units.
Okay, thank you.
Yeah, because you'll be working in partners. So whoever's the patient is going to need a clean unit to go to. And we can all take turns. We can all take turns. I like to think that even as a patient, you're still learning process of care. Any other questions?
One more question.
Yeah.
Regarding the discussion boards, do we have to, I know we have to do the two responses to like our like two
Don't,
classmates. Do we
don't you
then have to
love
respond?
discussion boards?
Wait, what?
Don't you love discussion boards?
Oi, do we then have to respond to them their questions to us, or we just had to ask a question?
Well, no, the whole idea of a discussion board is to discuss. So if somebody else has another question, you have to go in and follow up with that.
Okay.
Say that with a little more excitement.
Alrighty.
Yeah, yeah. You will have discussion boards, my friends, until you graduate. Um, it's just our way, like for this exercise, it's a way for me to get that ethics component that accreditation wants you to have. And that is also a not a big part, but it's on your boards too. All those words are going to come back and haunt you. Okay, so we are talking about caries today, and hopefully you have a fairly good understanding of caries so far, um, because you've made your notebook already for your OHE. But caries used to, or the philosophy of caries, how it's been formed, and how to treat it has changed probably 3 times since I graduated from dental hygiene school. Just the role of fluoride. We didn't even know what xylitol was, for example. So things continually evolve. And that's one reason why it's so important for you as a dental health care professional to join your professional association to take advantage of the literature that's coming out and being researched all the time, and go to or attend or read continuing education courses. When I was president of the Virginia Dental Hygienists Association way back when, um, that was one of the things that I was charged with by the state, is to have mandatory continuing education for all license holders. And so because of that, you are obligated to have 15 hours every year of continuing education, and it's very easy to get. We did not put any stipulation on it all has to be live, as some states did, or you can only have a certain percentage of certain types of courses. So you can do all of this online. And again, that's one reason why I want you to be investigating these online possibilities aside from dentalcare.com. But that's another assignment that you have, to do those 3 continuing education courses, because there are a number of possibilities where you don't even have to pay anything for. Now, I'm the CE chair of Northern Virginia, so I want you to be attending the courses and supporting your local hygiene association, but it's not possible for everybody. So, anyway, you've got a lot of flexibility. Your first year that you graduate, though, you don't need those 15 hours, because guess what? You are more on top of anything than most hygienists. But after your first year, you have to start accumulating those 15 hours. And the way that works is, if you have 30 hours one year, you can carry over 15 hours for another year, but you can't carry over for more than one year. So I mean, with COVID, I ended up, I think, with 126 hours of CE. That's all I was doing, was sitting taking CE courses. I had one office where we were obligated to take 40 hours a year because it was a perio office and it had to be perio related. And our my employer wanted us to be the best in the Northern Virginia area. Um, so depending on the office that you go to, some offices will help pay for CE, some don't. It's something that you might consider negotiating. This is your obligation as a dental hygienist, though, for license maintaining. I did notice a big difference. I'm getting on my soapbox now, but I noticed a big difference when I graduated from the hygienists that I graduated with that weren't taking continuing education courses, and me, for example, because fluoride, the role of fluoride has changed since we graduated, and they just weren't keeping up. So it's important that you have that lust for the most current information. And that's what I'm trying to instill in you, which is difficult sometimes, especially when you're an overstressed student. But things change. And caries management is one of those things that have changed. How does gum disease, periodontitis um, happen and how to treat it? It's changed dramatically since I graduated. Now, that was in the dark ages, but you are just starting your career. So I'm seeing that you will be going through similar changes as far as philosophies and how to care for things. But caries management um, really didn't start taking hold until the early part of the 20th century. And we're now in the 21st century, so we're even in a different century. But placing restorations, oh my gosh, you can see artifacts from Egypt and the pyramid times, and even BC, where teeth have been extracted and care and replacement has been attempted. Some of it's pretty crude, but some of it's pretty ingenious too, because the things we're doing today don't always look that much different from what they were doing many, 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 many years ago. Um, but since 1945, look at this, 40 to 60% caries reduction in communities with water fluoridation. That, my friends, is the most economical way to get fluoride protection to communities. And you're going to be getting into that more when you come into your community health in your second year. 40 to 60% caries reduction with communities with water fluoridation. Now, having said that, there are still communities that are fighting water fluoridation because they don't want the government telling them that they have to ingest this mineral. Okay, it's a self advocacy thing, but the communities that have removed the fluoride from the water oftentimes will go back and add it back in because of the cost that it's doing to the community, because caries is then coming back into the population. So dental caries is prevalent in some populations because of the lack of access to care. It might even be a lack of fluoridated water. Rural communities that have well water that don't have natural fluoride in them, they don't have the access to low dose repeated applications of fluoride. Some communities might not even be able to afford fluoridated toothpaste, so they're using baking soda and salt and other things, again, with no fluoride in it. So caries is a very prevalent, and it's considered a communicable disease. It can be passed from one mouth to the next. So we know that dental caries is an infectious, transmissible disease, but it's also preventable. And it's also repairable if we get to the lesion before it is actually cavitated. Now, our tooth surface is in a constant state of demineralization and remineralization. And what is the biggest factor for that demineralization and the remineralization? What do we have in our mouth that really aids this?
Saliva.
Saliva, yes. Okay, saliva is one of the main buffering agents that we have in our mouth. So we put something with a fermentable carbohydrate in our mouth within 20 seconds. That carbohydrate, okay, and that pH of our mouth has acted and it lowers the pH. That lower pH draws out minerals from the tooth surface and it enters the saliva. And then the saliva buffers to help put those minerals back into the tooth surface. So it's a constant give and take with these minerals. Hopefully, the buffering action will win out. But protocols exist to really address these caries, disease prevention and management at the various stages of the lesion. And depending on what your office protocol is, you might be instrumental in coming up with a caries prevention plan. And with the caries prevention, you are quote unquote educating the patient to sell certain products. You We took a caries risk assessment on you. You are at a high risk for this. We recommend that you have a fluoride varnish at the end of today. Well, is insurance covering that? That's always the number one question. Well, it probably isn't, but we're recommending this for you because of, all right, and you're really personalizing that. It's not that, oh, everybody gets a fluoride treatment. All right, this is why we're recommending this for you. And the basic caries process is the same for everybody. It starts with an acetogenic bacteria. You know what the name of that bacteria is?
Is it a streptococcus something or other?
Yes, it's the strep mutans. Strep mutans, absolutely. And then it interacts with the fermentable carbohydrate. So the more simple carbohydrate, simple sugar that you're putting in your mouth, the easier it is for that bacteria to interact with that sugar because the bacteria just it has a party. Oh boy, I'm getting fed. So the pH lowers. These type of bacteria love a low pH, and then acids form that in turn will demineralize the enamel, the cementum, and the dentin, and eventually lead to a cavity. So this is where those critical pHs come in that you've had to learn about. Critical pH for enamel versus critical pH for cementum and then dentin. The critical pH for cementum, does anybody remember what that is? It's very close to neutral. Neutral, okay, is 7, let's say. Critical pH for cementum, anybody remember?
Wasn't it like 6 point something?
Yeah, 6.6, 6.7. It's very close to neutral. So if your patient has a lot of root surfaces that are exposed, they are going to be more prone to root surface decay than somebody who doesn't because enamel has a much lower critical pH. So we have to have, in order for a cavity to form, we have to have acetogenic bacteria. Now, some people don't have strep mutans in their mouth. They're the lucky ones. Some do. Again, this is transmissible. It is so depending on who your primary caregiver is, you can thank them or not thank them for what type of bacteria is in your mouth. But there's specific bacteria in the biofilm that collect on the tooth surfaces that love this fermentable carbohydrate. And they are acid forming bacteria. They thrive in an acid environment. So you've got your strep mutans or your mutan streptococcus, depending on how the book wants to do it. I always call them strep mutans, as well as streptococcus sorbrinus. Okay, so those are your two, strep mutans and strep sobrinus. Then you've got your lactobacillus species. So an early colonizer, an early cavity producer is your strep mutans and your strep sobrinus. Okay, so they're your streptococcus. Then later on, the lactobacilli take over. So they've done studies where they can determine, is this a new cavity or an old cavity, so to speak, depending on the type of bacteria that's found there. But strep mutans, again, is an infectious organism that colonize on the teeth, and they help to form the dental biofilm because they create that sticky environment, and they create a nidus, they create a whole environment that the bacteria loves. So the streptococcus are really the most active during the initial stage of demineralization, followed up by what is the bacteria? That's the later colonizer.
Lactobacillus.
Lactobacillus. Look at this. You guys are sounding like microbiologists. But permanent colonization of the child's teeth with mutans, with strep mutans, can take place soon after the tooth is erupted. Now, before the tooth is in there, a susceptible tooth surface, the strep mutans aren't, they don't thrive. There's nothing for them to stick to. So we need acetogenic bacteria, we need fermentable carbohydrates, and we need something to produce acid formation. So we need a tooth surface for that acid formation to actually work on. So what they've found also is that these acids that are produced during the metabolic process, okay, you need to know, okay, you've got acetic acid, lactic acid, formic acid, and propionic acid. That's a lot of different types of acids. And a tooth surface might be more susceptible to one versus the other, depending on where it's located and if the bacteria is being disrupted. But the main thing is frequent ingestion of fermentable carbohydrates have a strong influence in the amount of acid produced and the extent of tooth destruction. So we've got this give and take of acids and pH. So the minerals are being leached out of the tooth surface. The saliva buffers, or you're having something very acidic, sugary. You have a bite of cheddar cheese, which helps neutralize the acid, or you swish with some water, which helps neutralize the acid. Then you have minerals going back into the tooth surface. So it's going in and going out and going in and going out. And they know that fluoride helps alter that hydroxyapatite, which is a mineral in the tooth, and it changes it chemically to fluorapatite, which is a stronger, harder, more resistant surface than the hydroxyapatite. So fluoride does change the surface of the tooth, as well as the root surface. All right, you've got to, we're not going to dwell on this because you have a whole semester on public health, but there are reversible stages of the carious lesion, reversible stages of the carious lesion. And that's the important thing to know. All stages do not need to be filled, but you have to have a caries management program in place to help remineralize. So we're not just putting watches on teeth anymore. In the old days, the dentist would go around and call out, we've got a watch on this, we've got a watch on that. I can see something interproximally on the bite wings. We're going to put a watch on that. And all you're doing if you're putting a watch on something is you're waiting it to get big enough to fill, because a watch is a tiny little lesion And in order to fill that and put a restoration on it, you have to make it a huge hole in comparison. So if we can remineralize the tooth surface, it will always look like that on the radiograph. It will always look like that, just like a broken bone. You'll always know it's been broken when you take an x-ray of a bone. But a remineralized tooth surface is actually stronger and more resilient or more resistant to acid than something that hasn't been remineralized. Reversible, it's great. It's great to get. The initial stage of caries, all right, can be remineralized. Then you've got your irreversible. And those are the larger carious lesions that have cavitation. That cavitation means that it's not going to be able to remineralize. The decay has gotten into far enough into that enamel or tooth structure. Then you also have extensive caries. So you're going to be getting into these next year, but just know that you have reversible and irreversible stages. We use a caries risk management. We modified it just a little bit from what the American Dental Association has. But after you're done with your EOIO, you go straight into your caries risk management. And that's asking your patient questions. Do you drink fluoridated water? Do you use an ACP product? Do you know what the ACP product is? Because you're asking them about that. ACP stands for amorphous calcium phosphate. And it's typically, if you're in the dental field, it's called MI paste, minimally invasive dentistry, MI paste, and it has calcium and phosphate in it. And it's just something, it's a paste that the patient puts in their mouth twice a day, just a little bit on their finger, and they swab it. And what that does is it helps activate that calcium and phosphorus that's being leached out of the saliva, and it allows it, those minerals, to be absorbed back into the tooth structure. It helps neutralize the saliva, and it helps fluoride be absorbed into the tooth structure as well. So if you've got a caries risk person or somebody with ortho, I routinely put them, if they had ortho, they were on MI paste as well as a prescription strength fluoride, just because of the surface area that the brackets and bands had. So there's caries risk management that your office should be doing. If they don't have it, maybe you can find a good one and introduce it. This is a good way to customize and introduce fluoride to your office if your office isn't using fluoride yet. You've got the American Academy of Pediatric Dentistry that is also doing a caries risk assessment tool. And then there's Cariogram. So all of these are assessment systems. Sonicare, the Philips Sonicare people also have assessment systems that you can download. There are systems that you can purchase as well that the patient can take a caries risk assessment, or an oral cancer risk assessment, and a periodontitis risk assessment. They can do those at home before they come into the office. Then you've got the data to help customize what you're going to be spending your time with the patient on. Because if the patient is at a very low caries risk, do they need to be having radiographs as frequently as somebody who isn't? Well, it all depends. Depends on what their periodontal case type is as well. But just because the ADA or the insurance company is saying, the insurance company is allowing, this is it, bite wings every 6 months, does not mean every patient should have bite wings every 6 months. Depends on their caries risk. I hope I'm making sense. So Canberra, caries management by risk assessment. Canberra is something you can look up, and you can print out the sheets. Okay, it is a specific one that's been made out. Another one is the International Caries Classification and Management System. That's what all of those initials stand for, again, they're readily available to you. So your office doesn't even have to purchase anything. And if you're paperless, you can, like we do, just ask the questions to the patient, or they can do something and they can bring in or have it done on the computer prior to their appointment, and it saves a great deal of time. So, Caries Risk Assessment, CRA. Okay, we want to identify which risk assessment system is going to be best for the office. We need to identify the risk factors for caries for that particular patient. And we want to use radiographs and clinical examination also to assess our risk factors. Part of the caries risk assessment that you do in clinic has you looking for the amount of biofilm, white spot lesions, those type of things. Then we put those together and use our clinical judgment that results in the risk assessment to help identify the risk level as well as modifiable risk factors. Are they snacking on cariogenic foods throughout the day? How often are you snacking? Are you drinking regular soda? All right. This stuff doesn't necessarily cause cavities if you're consuming those in the proper way. So again, it's how frequently are you being exposed to those fermentable carbohydrates. So we've got more caries risk management systems here. So the whole idea is we want everything that we do for our patients to be individualized. We do tend to feel like little robots occasionally because we are very task oriented. And, you know, first we do this, then we do that. And then this comes, and then this comes. Those are our tasks that we have to do at each appointment. But we want to individualize our care for the patient. Again, how frequently do they need their bite wings or their radiographs taken? Do they need to be placed on some sort of a caries prevention program? What is their periodontal case type and what is their prognosis for that? So all of this provides a framework for what we are going to be talking to our patients about. It's all the information is there. We just have to customize it and individualize it for that particular patient. So planning for care, you're going to have your patients with a low caries risk, a patient with a moderate caries risk, and a patient with a high or extreme caries risk. And those are the ones that already come in with cavitated lesions that aren't being taken care of. So this is going to drive, again, the frequency of your care appointments. So at each appointment, you're doing a biofilm control assessment. That's your plaque index. You have two-toned disclosing solution, so you can see what the new plaque is, which is the pink, and the old plaque that's been on there for 24 hours, and that's the purple. GC America has a three-toned, which is pretty cool. I'm going to get that out today, a three-toned disclosing solution. That's a gel that some hygienists like to use. And what that also identifies are the strep mutans, the cariogenic bacteria. They turn out green. So again, you can customize what the patient is seeing. So you're taking your a plaque index. You're always reassessing a caries risk, not from appointment to appointment if they're being seen more than once in clinic, but from recare to recare. Because things change. Stress changes. Lifestyle can change. The clinical detection for mineralization areas you're checking for, you need sealants. You all have to have sealants in order to graduate. So if you have an adult patient in your chair, even though they don't have any caries risk, if they don't have fillings or sealants, think about doing sealants because they're not going to harm the patient, and especially if it's a friend or family member. They get them for free and you get the practice. So we have some adults that are in their 30s coming in for 14 sealants. They have never had a cavity in their life, but guess what? You're getting all of your sealants out of the way with one patient. So always be thinking of things that you can be doing for your patient. Now, in private practice, that would be frowned upon, but we are not charging the patient for this, and it is an educational facility. So we're always looking for things that we can do to enhance your learning. Poor margins of restorations are considered plaque traps, plaque retentive surfaces. What is the frequency of radiographs? If they're at a high caries rate or high caries risk, they're going to need bite wings more frequently than somebody who hasn't had an interproximal decay ever. I have never had a cavity in between my teeth, ever. I've broken teeth, so I've got crowns, but I've never had a cavity in between my teeth. So I might not, and my gum, hopefully my disease process is stable. I'm not going to need radiographs as frequently as somebody who has cavities routinely every time they come in. Do I get bite wings taken frequently? Oh yeah, because there's always a student that's, I can't graduate until I have another set of bite wings. So I tend to get them frequently, as do other faculty members. You will be learning how to do sealants this summer in dental materials. And after you have that and you pass the skill evaluation in dental materials, you can then do sealants. We used to do dental materials, it's 214 is the class number, and anything two was considered second year. We used to have that in the fall, and we changed it because we found that students had more access to children and those type of things, kids that really needed the sealants in the summer. So we bumped that up to summer. So by about the fourth week of summer. Kind of off topic, but are we going to have more clinic days to see patients this summer? You are going to have clinic schedule. I already have it, and I've got the clinic. It's going to be on Mondays and Wednesdays. They're going to be 8 to 12 and 1 to 5. The clinics are going to be longer, and you're going to have 2 full days of clinic. So yes, you will have more clinic days. Summer is when everything clicks and you do, and then by the time you're in DNH 244, you are off and flying. So these risk assessments, all right, you are customizing for your patient. You're assessing the patient compliance. You're doing a plaque index each and every time the patient sits in your chair once you get to that part of the process of care. So you're talking to them about the percentage. Well, you were 68%. 68% of your surfaces were covered with plaque the last time you came in, or biofilm. Today it was only 32%. That is great. You've halved the amount of biofilm that's on your teeth. You know, now we like to see 10% or less, and you're always trying to up the patient's game to get them in the best shape possible. Amanda, I believe those are the dates. It's going to be 6 weeks. We used to have 8 weeks. This will be the first summer we're doing 6 weeks. So I believe those are the dates. It's usually a week after spring semester, and then count up 6 weeks. You all are already planning your summers. Okay, so again, everything needs to be documented. Everything needs to be documented. Because if it's not written down, it never happened. So with that, you want to write down that you verbally gave them instructions and you gave them written instructions or any pamphlets as well. That's important if you are ever taken to court, that you said, no, I told them about it and I gave them this handout or whatever. And then you have a sample of a handout. So the patient can't say, well, they never told me. Yeah, I told you and I gave it to you. But what specific self-care and dietary changes were recommended in meeting those goals? And you work with those goals with the patient. You educate the patient, and then you come up with goals the patient, especially with OHE. What changes do you think you can make? What's reasonable for you between now and the next time you come in? And that might be, I promise to brush once a day. Is that ideal? No. But if they're not brushing once a day, that's big. So we take what we can and we make things reasonable. Oh, I don't brush every day now, but I'm going to be brushing twice a day. I'm going to be flossing and using a water pick. That might not be reasonable. Okay, baby steps. So we've got that. You can also follow up with the patient. Things like the Sonicare, the Philips Sonicare Oral B, they have things in place where the patient can actually sign up for, and you can do that chair side, where the company will be sending them reminders to do things. Same thing with smoking cessation. There are things that the patient can sign up for that will have that digital reminder for them, and go team. But you want to also note the patient comments and whether or not they seem receptive. And each time you're setting new goals. And it might be the same goal. Yeah, I thought I was going to brush every day, but such and such happened. Okay, well, why don't we still work on that as a goal? You work on it together. And with the OHE skill eval, the important thing is to have the patient come up with those goals. So we're always trying to leave our patient with more information than what they came in with. I love the patients that I've been seeing for years, and we can just sit down and catch up on family news and everything else. But again, your job as the oral health professional is to be there for the patient. So sometimes it's while you're sitting talking, sometimes it's while the patient's back, and you're probing and you're noticing that they're missing this area here or whatever. You're just pointing things out, or the gum tissue looks a little boggy here. So you're always talking with your patient about that. What demineralization means and how can they prevent it. Remember that pH, that critical pH is important. And once they put something that's cariogenic in their mouth, it takes 20 to 30 seconds. I learned 20 seconds. We tend to say 30 for the patient because they can do the math easier. For that pH to drop, that pH stays low for about 30 minutes, 20 minutes, 30 minutes, okay? That pH stays low. So during that time, demineralization is happening for that entire time. And then the buffering starts with the saliva. So it's important to calculate the amount of carbohydrate exposures that the patient is having. And you're going to be doing this when you get into your nutritional counseling. The Caries risk assessment, you're kind of doing it. You're not using numbers or anything, but how many times are you snacking throughout the day? And what do you snack with? Snacking on a carrot is going to be very different than snacking on a raisin. Parents love giving raisins, little boxes of raisins in their lunchbox. But guess what? A piece of chocolate, milk chocolate, is probably better than a raisin. And why would that be?
Because the raisins stick to your teeth for longer.
All right, I can't hear you. Your microphone's wacky today.
Doesn't stick on the tooth.
The raisins stick in the teeth. Exactly. So you want something that will flow off the teeth, all right? Because raisins is a grape where all the water has been taken out of. So a raisin is just as bad, just as much sugar as a piece of candy. So think about the retentive factors. that food has, and also think about the frequency. So it's okay to eat M&Ms. It's okay to have that candy bar. It's okay to eat those raisins, but do it and do it all at one time, because from the time you take that first swig of regular Coke or Red Bull or whatever it is, that pH has already dropped, and that pH is going to stay there for the entire time you're eating or drinking, plus 30 minutes. So the philosophy is eat it, drink it, but do it all at once. And it's best to do it with a meal because your pH has already dropped. So it's better to do it and get it over with versus munching on something throughout the day. Because what you're doing then is you're just continually dropping that pH, even though it might be a piece of fruit. Grapes, okay? Grapes are better than raisins, but they still have sugar in them. So if you've got strep mutans in your mouth, it's feeding that. So you want to come up with a plan to help your patient. Great. Okay, eat it, drink it. I'm not going to take you off your Red Bull, but just drink it. Don't spend the whole morning sipping on it, and then rinse out with some water. Swish, spit, swish, swallow. Put something with xylitol in your mouth. Remember those strep mutans? They love sugar. Well, the xylitol is a sugar that the strep mutans love because they think it's regular sugar, but they can't digest it. So what you are doing when you're taking, say, gum with xylitol in it, now it has to be one of the first 3 ingredients for it to work, but xylitol actually starves the bacteria because it's ingesting it. Oh boy, I've got my meal, but it can't digest it. It ingests it, but it can't digest it. So xylitol is a great, great product for caries control. Now with gum and with xylitol candy and those type of things, it also draws fluid to your colon. So if you're not used to some of these different sugars, substitute sugars, you can have GI upset and diarrhea with that because of the water pooling. Your body does get used to it. So you want to fool the bacteria. You can't remove all the strep mutans, but you can starve them to death. There's also, if somebody is coming in every 6 months and they have a lot of decay, we're now doing saliva testing, checking the pH. What is your natural pH of your saliva? You could have a naturally acidic pH. So that's the person that needs to be using baking soda toothpaste, MI paste, and other things to help control that pH that's inside their mouth. There are a lot of things that we can do to help our patients. A patient who's gone under chemotherapy will have a more acidic pH in their mouth than somebody who hasn't. Somebody who's had head and neck radiation, they're not going to have more acidic pH, but they're going to have less saliva also. So less buffering. Patients that are on multiple medications that dry the mouth out. All of this is going into your caries risk management and how you're going to be talking to your patients. Now, I've just had grapes and everything else. Do I go and brush my teeth right away? What does common sense tell you? Okay, well, I'll answer for you. All right, you don't brush your teeth right away because think about that demineralization that's just taken place. The calcium and phosphorus has been leached out of the enamel, so your teeth, in a sense, are more porous. They're softer, to use lay terms. Okay, some of that calcium's been leached out, so you don't want to be scrubbing with an abrasive like a toothbrush right away. You want that patient to be swishing with some water, eat a piece of cheddar cheese, doing something else, waiting a half an hour, and then they can put that fluoride on the tooth surface with their toothbrush. But swishing with fluoridated water is one of the best things that they can do. Okay. Any questions? Okay, it's 9:01. Let's come back at 9:06 and we will do another chapter.